Everybody, we're going to get started. My name is Bryson Keith. I'm one of the chiefs. I have the honor of introducing our speakers today. The first one I have the pleasure of introducing is Dr. Susanne Doblecki-Lewis. She's a professor of clinical medicine and the chair of the chief of the Division of Infectious Disease at the University of Miami. Her clinical research focuses mostly on research in HIV as well as infectious disease prevention, mostly in the underserved communities around Miami. She is currently the director of the RAPID program, which I'm sure many of us are familiar with, but what that really does is looking at HIV treatment and STI prevention and HIV prevention with both a mobile clinic as well as a fixed clinic here just on the outskirts of campus. She has received numerous grants related to delivery of HIV healthcare, long-acting injectables, which are becoming a really wonderful thing now for a lot of our patients. And she also directs the ID Prevention Clinic Research Unit, which has a lot of trials in prevention of HIV, monkeypox, and many other diseases. Please welcome Dr. Doblecki.
Thank you. Okay. So this is a mixtape. So for my fellow Gen Xers, I know there are a few of you around. I see you. This is a mixtape is what you make when you want to share your favorite music with your friends and the people you care about or who are special for you. So for the next 20 minutes or so, I'm going to share what I think are some of the most interesting and potentially practice-changing work in the last year for infectious diseases. So here's our playlist. Oh no, my font changed. Okay. So we have some new data on the treatment of bacteremias, transition from IV to PO, ongoing Staph aureus trial that I think is really exciting, some new drugs for UTIs, and then we'll talk about long-acting PrEP a bit, one of my favorite topics, and its implementation, an update on Mpox, the artist formerly known as monkeypox, and a little reflection on our current political climate and funding situation that I will call deep cuts. So first, my disclosures. I do have some research funding, both from Gilead and from Merck, and I'm the site PI for the Gilead Purpose 2 and the combined Gilead NIH Purpose 4 studies, both of which involve lenacapavir, which I'm going to speak about briefly, and the NIH STOMP trial, which involves tecovirimat. So most antibiotic courses are not evidence-based. And we like to say that if Constantine had declared the week to be 4 days long instead of 7, we would be giving antibiotics in courses of 4, 8, and 12 days instead of 7, 14, and 21, or what we call the Constantine unit of 7 days. But we know that there are risk factors for longer prescribing. Some of them are listed here. And ID specialists are not immune from this either. So more than 30% of ID specialists in a survey did not generally recommend short course therapy, even when there was evidence for it. So we've got a lot of work to do here, but we do have also a lot of data accumulating for short courses. So there's some obvious benefits to shorter courses of antibiotics. Despite what many of us may have learned from our grandmothers, taking a longer course of antibiotics or taking the full course of antibiotics does not prevent resistance. And in fact, resistance develops when we take antibiotics for longer than is strictly necessary to eliminate the infection. Obviously, we'll get more adverse effects from antibiotics when we use them more, increase C. diff infection. And of course, cost becomes an issue and more antibiotics cost more. So we already have quite a bit of data on shorter course. So that's 1 or less Constantine unit or 7 days for some of the infections that I've listed here, and even more than that. And I do recommend Brad Spellberg out of UCLA has a really extensive and really complete website on short course antibiotics with tons of data. And he's a huge advocate for us using only what's needed in terms of antibiotic duration. So I listed his website here, and I definitely recommend it for a deeper dive into the data. But most of these studies have excluded bacteremia. And the ones that did include bacteremia were mostly underpowered small studies or observational studies. So enter the balanced trial. So the question here is, can we safely decrease the duration of antibiotic administration for our sick bacteremic patients? And so historically in this population, we're looking at about 15 days on average of antibiotics for bacteremia. So to accomplish this, they enrolled over 3,000 patients, about 3,600 patients. It took them 10 years to do it, which is kind of an issue because practice changes over 10 years. They excluded Staph aureus, which is, for obvious reasons. We have data that less than 14 days is probably not sufficient for Staph aureus. And they randomized to 7 days or 14 days. They would reveal the treatment allocation at 7 days. So the physicians did have an option to continue if they had a good reason to do that, but it was suggested that they should stop at 7 days. And their endpoint was 90-day all-cause mortality. This is a non-inferiority trial, and most of the patients were in the ICU. So looking at the outcomes here, first of all, you can see that even though it was meant to compare 7 to 14 days, the mean duration of antibiotics was about 8 days, and almost a quarter of patients got more than 9 days. So there's some physician noncompliance here. These were sick patients, so things can come up. May have developed a new infection or had shock or something else that would require them to continue to get antibiotics. But when you look at both the intention to treat and the per protocol arm, there was non-inferiority in the short course arm. So I think this is actually pretty good data to support the safety, most importantly, and the efficacy of short course treatment for most bacteremias. And again, we're excluding here are really bad pathogens like Staph aureus, as well as Funkemia and a few other things. But in general, pretty good data that 7 days is probably what we should be aiming for here. So balance excluded Staph aureus bacteremia, and Staph aureus is sort of the original bad guy on the infectious disease service. I always tell our rotating residents and students that their main take-home message from rotating on the ID consult service should be that Staph aureus is to be respected as a really bad guy. It has a case fatality rate of 15 to 30% and causes a lot of metastatic infections, relapsing infections, and about 300,000 deaths worldwide. So we know that we need to treat, or it seems like from data we have so far, for at least 14 days, even for uncomplicated Staph aureus bacteremia, to prevent relapse or complications. But the question here is, can we switch to oral therapy after 7 days, which might help people to go home, for example, without a PICC line? So this was, again, a non-inferiority trial, and the primary outcome was complications or death by 90 days. So my take-home message from this is that uncomplicated Staph aureus bacteremia is actually pretty rare. So when you look at the number of patients that they needed to screen, and this was over 5 years, it was over 5,000 patients. They did exclude anyone who would have complicated Staph aureus bacteremia, which I think is part of the issue with screening here. And they only randomized 213. They actually stopped and analyzed the data because it was taking so long to accrue patients. And when they did show non-inferiority in terms of their primary outcome, which was Staph aureus related complications in 90 days. They also showed that there was a statistically significant decrease in length of stay for people who switched to oral therapy. So I think that this is encouraging and shows us that there's proof of concept that it might be possible to switch some of our patients with uncomplicated Staph aureus bacteremia to oral therapy. However, I would say also that Staph aureus bacteremia is one of the infections for which ID consultation has been consistently shown to improve outcomes. So a little plug for ID consult. This is a graph showing mortality and out to 5 years in people with Staph aureus bacteremia who did and did not receive an ID consult. So, excuse me. I think that it may work for uncomplicated bacteremia. Uncomplicated bacteremia may be hard to define, and I would be really careful about applying this more broadly. Thank you. And again, plug for ID consults when needed. And then this is the study that I'm a little excited about. I think that there's been a lot of fanfare about the SNAP trial. This is, again, for Staph aureus. This is adults and children, and it's a continuous enrollment Bayesian adaptive trial, which means that they are going to just continue to enroll lots and lots of patients and add treatment arms as needed for different durations and combinations of therapy. What I think is impressive so far is the enrollment. So they've already enrolled more patients in this trial than in any previous Staph aureus trial, Staph aureus bacteremia trial. Sorry. And you can see their target is to have 5,000 or 7,000 patients over 5 years, which is going to be more than all of the previous Staph aureus trials added together. So really it's stay tuned on SNAP, but they did show some preliminary results at the European conference just last month, and people were really excited about this because if you want to start a debate among ID physicians, just ask whether cefazolin or oxacillin is better for MSSA bacteremia, and leave the room, and they'll still be at it an hour later when you come back. So they used this trial design to look at a pretty large sample. And they used flucloxacillin, which is basically equivalent to oxacillin. And we're able to show that in this Bayesian adaptive way, which shows a probability of non-inferiority and a probability of superiority, that the probability of non-inferiority of cefazolin is over 99%, and that the probability of superiority at using 90-day mortality is almost 90%. But even more important, I think, is that the risk of acute kidney injury was much, much higher in the flucloxacillin arm. So the probability of superiority for that outcome was more than 99%. So I think a lot of folks are now really using cefazolin as first-line therapy for MSSA. And this supports a lot of observational and previous data as well. So I think this is the take home from the study right now, and lots more to come. They also have an early oral switch arm that's underway. So we'll get some more data, hopefully, to support the Sabato data. Okay, moving to gram negatives. So I wanted to mention a couple of new drugs for both of these were approved for uncomplicated UTI, but may have other uses over time. We'll see. The first one is I had to write it down. Gepotidacin, which is, once we start using it, we'll learn how to say it. This was FDA approved in April of 2025. So it should be available, according to the manufacturer, later in 2025. And has some susceptibility among resistant gram-negative rods. It's obviously orally bioavailable. And like I said, it was FDA approved for uncomplicated UTIs. We desperately need agents for people who have ESBL organisms and other resistant gram-negatives, so they can be treated in the outpatient setting, because these are becoming much more common over time. There's also, which is exciting to me, data for treatment of gonorrhea, which is one of the bacteria that's really accumulated a lot of resistance over time and is on the list of biggest threats for multi-drug resistant organisms. And it was shown to be non-inferior to the standard treatment of ceftriaxone and azithromycin. So more to come on this, but I think there's a lot of promise for this agent, and we will learn how to say it as we learn how to use it. The other drug that's coming up is sulopenem probenecid. So this is a little scarier. It's an oral carbapenem. It was FDA approved in October of 2024, again for uncomplicated UTIs. They tested it and did not see efficacy for complicated UTIs. I think the thing here is it is obviously from the well-known family carbapenems, which we use extensively for our most serious infections in the hospital, and we really don't want to lose carbapenem susceptibility. So I think all of us will have to be very cautious about how we use this drug. Having said that, I can see a lot of potential for step-down therapy, maybe, or oral treatment very carefully. So we may see additional crackdowns on treatment of asymptomatic bacteriuria to try to avoid losing both of these drugs. Okay, now switching over to HIV and STIs. I wanted to talk a little bit about long-acting drugs for HIV prevention. So we have currently approved options for HIV PrEP, pre-exposure prophylaxis. Two of them involve variations on tenofovir and emtricitabine. These are daily oral pills. And then we have cabotegravir long-acting formulation, which is given every 2 months as an injection. And we've seen good data. Now, this is 4-year-old data on cabotegravir versus, in this case, tenofovir emtricitabine. And you can see that it seems to be more effective in prevention. This is probably entirely due to the ability to not rely on people taking the pill every day. So it's really an adherence effect, but still very exciting. What's less exciting is how slow the implementation of long-acting cabotegravir has been in the US. So when you look at the fourth quarter of 2024, for example, here, you can see that only 2.7% of new PrEP starts were with cabotegravir. So this has been a real slog. The main reason is cost and difficulty with insurance approvals. It's really not easily accessible to clinics, even who are pretty aggressive about trying to implement it. We and others are working hard to try different ways of implementation, using navigators, using mobile clinics, because I think there's a lot of promise here in ending the HIV epidemic, but so far it really hasn't been able to fulfill that promise. We have a new kid on the block, or we will soon, which is lenacapavir. So lenacapavir is a subcutaneous capsid inhibitor, and it's an injection every 6 months. It's a subcutaneous injection, whereas cabotegravir is intramuscular. We had 2 trials within the last year, both published in the New England Journal, demonstrating that it was highly effective, both for women as well as for men and gender diverse people. And really the trial for women was published first and was really exciting because adherence has been a very difficult problem to overcome among cisgender women who are at risk for HIV. And you can see from the data on top here, the lenacapavir every 6-month injection arm had 0 infections, which caused a lot of statistical confusion about how to handle that, but it's nevertheless a very good thing. And you can see the background rates for HIV. This was not placebo-controlled, obviously, for ethical reasons, but they did look at background rates among similar population, as well as women who were enrolled in the trial and were on the 2 different versions of tenofovir emtricitabine. So very significantly favorable for lenacapavir here. I would also note that both arms with tenofovir were indistinguishable from background. So I think this really could be extremely important for women who make up the largest population of new HIV infections in the world, and particularly in Africa. And then in the parallel trial for men and gender diverse people, it was also favorable for lenacapavir. There were a few infections that occurred in that group, but still favorable compared to background and compared to tenofovir emtricitabine. So I think the question here is, will it be well tolerated in the general rollout? So far has been well tolerated. There are some injection site nodules, but these seem to resolve and get better over time. But moreover, can implementation really keep up with this? We saw what happened with cabotegravir so far, which has been a bit disappointing. And I think the microscope will be on lenacapavir to see if we can do a better job of rolling it out. So I wanted to mention Mpox. Mpox is not gone. However, it's faded a lot. So if you look at the epidemic curve on top, this is from 2022. And then on the bottom, this is from 2025. The axis on the top is 100 times. The y-axis is 100 times what the bottom graph shows. So cases have gone down enormously. I think some of this is underdiagnosis because people aren't thinking about Mpox anymore. And that's one of the reasons I wanted to show you these slides. So if you see lesions, especially vesicular lesions, they can look scabbing when they're healing, and sometimes can be pretty atypical or more extensive, especially in immunocompromised people. Still think about Mpox, please. You can send the swabs to commercial labs and let's diagnose it. It's definitely still circulating in our community. And just a few lessons that we did learn from the Mpox outbreak, especially in 2022. This was a clade 2B outbreak in the US. Clade 1 outbreak in Africa is still ongoing, really hasn't subsided. It's likely a consequence of declining smallpox vaccination and sort of leaving open that niche for pox viruses. There have been 2 studies of tecovirimat, antiviral for treatment of Mpox, one in the DRC that was called PALM 007, and the STOMP trial that was through the NIH here in the US, and we were a site for that. It showed that tecovirimat is safe, but it did not demonstrate a reduction in the time to resolution of lesions or really, honestly, any other parameters. So it's not currently recommended for treatment of Mpox, and we really don't have any approved or recommended treatment except for people who are severely immunocompromised. If you encounter someone who is severely immunocompromised with Mpox, please consult with us and the CDC. There are some combination therapies that are possible, but really nothing that's proven. And a reminder that the repurposed Jynneos vaccine works. So the efficacy is about 2/3 to 90% based on observational data. It was never tested in a controlled trial. And this is still available. So a lot of pharmacies do have it. If you need to know, you can ask me, and I know which ones. And I recommend it for your patients who may be at risk. It's a 2-dose vaccine, very well tolerated. And I would not declare Mpox gone. I think we may see a resurgence again in the future. Okay. So finally, I wanted to talk about doxycycline post-exposure prophylaxis. So this is when people take doxycycline, usually 2 tablets or 200 milligrams within 72 hours of condomless sex to prevent sexually transmitted infections. This has been studied in 3 randomized controlled trials. I'm showing the results of one of them here, where looking at the outcomes with doxycycline post-exposure prophylaxis for both people who are on PrEP as well as people who are living with HIV. And you can see the overall STI reduction is pretty impressive. For chlamydia and syphilis, it's more so. So we're talking about around 75 to 80% for chlamydia and syphilis, and in the 50 percentile range for gonorrhea. There was another trial, similar trial, that was done among cisgender women, and it did not show efficacy. This was, again, probably likely adherence related. They did hair samples, and less than 1/3 of the women had doxycycline ingestion evident in their hair samples. There's no biological reason why it wouldn't work for women that we know of, but we don't have a strong recommendation for it because we don't have any randomized controlled data on it. But this has been recommended by the CDC as an intervention for men who are at risk for STIs. But San Francisco did a real-world analysis looking at the impact after they put out guidelines for doxypep, and they did show citywide pretty impressive drops in chlamydia and syphilis, but not gonorrhea, which has caused a little consternation in terms of concern about resistance. So there's a lot of questions that remain, and some of them are listed here. We were excited to be part of the Doxy Impact Study, which is across 5 sites, evaluating the field effectiveness, antimicrobial resistance, and implementation factors related to doxypep, but this was canceled. So that brings me to my final track. So this was not the only study that was lost from the ID division. So we lost important work on HPV and anal cancer from Dr. Isabella Rosa. We lost work on transgender care engagement by Dr. Alan Rodriguez. And there's been a huge impact on our colleagues here in adjacent fields and at other institutions. And about a third of all of the federal cuts in research have been on ID-related topics. So I am optimistic, despite all that, that we'll find new and creative ways to serve our patients and our community, because they really need our support more than ever. And I think we'll form new collaborations and we'll find support maybe from unexpected places. But I have 3 concluding thoughts or asks for you as a group. Number 1, prevent when you can instead of treatment. Number 2, treat only as long as you need to. And number 3, in the spaces where you have power, if it's in your clinic, in your community, or with your legislators, please help us advocate for ID. Thank you.
Questions, perhaps? Very eloquent and beautifully presented. Thank you, Suzanne. So when you said drop doxy, you didn't mean drop giving it. What did you mean by that?
No, I was just trying to be
cute. Okay, good. And I like your playlist very much. We have the same taste in music. And I think all those points are extremely well taken. And ultimately, it's our patients that we care most about. And that's what we're passionate about and what motivates us every day to come to work and investigate and do all the things that we do. So I thank you and the entire ID service for doing that. We have time for one question. First you, and 2 questions. Okay. Make it quick.
Yeah. I was just wondering, I had heard some like recent data that possibly the meningitis B vaccine might be useful in PrEP. If you could just touch maybe what you know or where that might be helpful.
Sure. So interesting question. There are some ideas, well, because meningococcus and the gonococcus are similar. So there is some idea that there's cross-reactivity in vaccination, that meningococcal vaccine might be useful for prevention of gonorrhea as well. There was some data presented out of the group in France regarding this. It was later sort of retracted. So it remains an open question. So there's ongoing analysis. There is some interest from the manufacturers of the meningococcal vaccine in testing whether it would be effective in preventing gonorrhea. So, and it may be, there's a scientific reason to believe that it might be. But I think that in terms of real world data or clinical trials data, we're not quite there yet.
Thank you for a wonderful talk. It was remarkably clinically appropriate. And after 40 years of private practice in medicine, short-acting antibiotics, in my experience, are quite appropriate and effective. So thank you.
Thank you.
Okay. Thanks, Dr. Doblecki-Lewis. Bryce.
And I will just say on a personal touch, as someone who is on cabotegravir, thank you for everything that you guys do. We really appreciate it. So next up, I have the pleasure of introducing Dr. Orr, who recently joined the University of Miami Miller School of Medicine Department of Digestive Disease Health and Liver Diseases in September of last year. Dr. Orr received his medical school degree from UIC in Chicago, residency from the University of Alabama at Birmingham, and did fellowship in an advanced year at Vandy. He focuses mostly on interventional GI and specifically pancreatobiliary systems, and today he's going to talk to us on endoscopic ultrasound-guided gallbladder drainage in cholecystitis. Thank you, Dr. Orr. Welcome.
Thank you. Thank you, guys. Thank you to Dr. Wise, Dr. Despande, and the rest of the committee for inviting me today. Let me get out of this presentation. Okay, so EUS-guided gallbladder drainage and acute cholecystitis, the gateway to the gallbladder. My learning objectives today for this clinical vignette is hopefully by the end of this discussion, you'll be able to understand the role of EUS-guided gallbladder drainage and acute cholecystitis. And then also recognize that there's a paradigm shift in the treatment strategy for acute cholecystitis in the non-surgical patient, and help identify suitable candidates who may be able to undergo EUS gallbladder drainage. I have no conflicts of interest to disclose. And so to start our presentation today, this is a recent case of mine. This was a 74-year-old woman with a medical history significant for compensated cirrhosis due to metabolic liver disease, hypertension, and hyperlipidemia, who presented to the emergency department with acute onset right upper quadrant pain and for the past 1 to 2 days, and radiation to the back with associated nausea and vomiting. Got it. Thank you. So some clinical data for her. You see some slight electrolyte abnormalities with a slight hyponatremia and hypokalemia. She had a marked leukocytosis of 25,000. Total bilirubin was slightly elevated at 1.8 with an alkaline phosphatase of 219. Slight prolonged partial thromboplastin time, otherwise normal INR. And this data calculated to a MELD score of 13, but clinically she was mild class of cirrhosis with a Child-Pugh class of A. Her vital signs were unremarkable, and her physical exam showed was consistent with right upper quadrant tenderness, no non-distended, no rebound tenderness, and no guarding was present. So looking at her CT scan, you see a cirrhotic morphology of the liver. You see the nodular contour in the periphery of the liver with a fairly unremarkable biliary system, except for her gallbladder. As you see in the picture here, she has multiple gallstones layering in the dependent portion of her gallbladder, with a distended gallbladder, the gallbladder wall thickening, and then a significant amount of pericholecystic fluid. So all of this was consistent with acute cholecystitis with her presentation. She was evaluated by a surgical service and felt that given her underlying cirrhosis and other comorbidities, that surgical resection may not be the best option for her. And so our GI service was consulted to evaluate for non-operative management of her cholecystitis. The technology that makes this a possibility is the lumen opposing metal stent. This is a nitinol stent that's covered with a silicone membrane that has with bilateral flanges and a dumbbell configuration that allows for us to bring two structures in close proximity and in close apposition to create a fistulous tract. Present LAMs are suited with a cautery enhanced tip, which allows for a single step delivery platform that's deployed under EUS guidance, under direct visualization, for the drainage of abdominal fluid collections, decompression of obstructed ducts, and also fistulous tract formation and new anastomoses. This stent has recently garnered FDA approval for the treatment of acute cholecystitis for patients who are poor surgical candidates in August of 2023. Some of the original indications for LAM's usage traditionally was for the treatment of inflammatory pancreatic fluid collections, in which we can drain walled-off necrosis or pseudocysts of the pancreas, as you see in the top picture, and then also drainage of the obstructed bile duct due to malignant biliary obstruction, as you see here with EUS-guided choledochoduodenostomy. And so this has been a game changer in the world of therapeutic GI, and allows us to treat patients with all different sorts of disease and conditions. In this pictogram, it shows the stepwise process of EUS-guided gallbladder drainage, in which case you see the echo endoscope being passed into the duodenum and finding a suitable place in the gallbladder to puncture the gallbladder, after which the distal flange of the stent is deployed, and then the system is retracted into the scope to bring the gallbladder in close apposition to the luminal GI tract. and then the proximal flange can then be deployed to ultimately deploy the stent. After which bile can freely flow into the duodenum or the stomach if that's a better place for stent placement, and the gallbladder can be relieved that way. And so that's exactly what we did. And so for this patient, you can see in the top left picture, initial evaluation of the gallbladder shows significant stone burden, creating shadowing artifact within the gallbladder. So we couldn't identify a suitable location at that position. But scanning the longitudinal view of the gallbladder did demonstrate an area that we could puncture the gallbladder. You see in the bottom left corner, and then subsequent stent deployment when you see the flange of the stent being deployed and then being retracted up to the gallbladder. Yeah, I don't know if I have a pointer on here. You can see that this is the catheter being tapped into the gallbladder lumen, and then under EUS-Guided, you see the distal flange of the stent is deployed and retracted to the lumen of the duodenum, which is here. And then the stent is subsequently deployed within the
I think you might have
the
a
scope
with this guy here too.
Oh, perfect.
Yeah. The top end.
Okay, thank you. And so the stent is then deployed within the scope, and then passed into the lumen of the small intestine to where it'll eventually sit. And so that's what we see here. And I apologize for the oversaturated pictures, but what you can see in the top left corner is the stent sitting in the lumen of the duodenum. And then also at the gastric outlet in the top right picture. And then ultimately what you see is the pooling of a purulent bile within the stomach and relief of the cholecystitis for this patient. So when she woke up from the procedure, she immediately felt better with resolution of her abdominal pain. She was subsequently monitored in the hospital for 3 days as we saw her clinical status improve, her white count come down, and we continued her antibiotics for a recommended period of time of 5 to 7 days, I believe. Maybe shorter would have been better, I'm not sure. So the neat thing about EUS gallbladder drainage is it allows for us to perform direct visualization of the gallbladder with per-oral cholecystoscopy. And that's what you see here. And after about 4 weeks, we brought the patient back, and we were able to traverse the LAMS to directly visualize the gallbladder. And this allows for us to treat any remaining stones and ensure that stone burden has been cleared, and then to provide other treatment options as far as stent management goes. For this patient, we passed the endoscope directly into the gallbladder and visualized that all the stones had passed via the LAMS, and that the cystic duct was then patent. And you can see in the bottom left corner and the bottom two pictures that looking at the cystic duct, it was no longer obstructed and free of stones. Furthermore, what we could do is inject contrast and directly visualize contrast passing from the cystic duct into the main bile duct and ultimately into the duodenum, which demonstrates that the cystic duct obstruction had cleared and the cholecystitis was treated. So for this patient, we removed her stent and discharged her from our service as no follow-up was needed. So acute cholecystitis is a well-known process and well-known illness for our patients. It occurs from gallstone obstruction of the cystic duct in about 90 to 95% of cases, with the remaining percent of cases due to acalculous cholecystitis. And this is a common condition of about 200,000 cases per year. It has a direct annual cost of $6.3 billion, and about 10 to 15% of adults have gallstones, with 20% of these patients will go on to develop gallstone-related complications at an incidence rate of 1 to 4% annually. This illustration further clarifies or depicts the pathogenesis of cholecystitis, with cystic duct obstruction leading to eventually can lead to gallbladder wall edema and early necrosis, with about 10% of cases developing gallbladder perforation. Cholecystectomy remains the gold standard for treatment of acute cholecystitis. And for the healthy patient, a healthy individual, the risk profile remains quite low, with low rates of infection, blood clot, bile leak, and even death. Early cholecystectomy is recommended for patients, as this results with a shorter mean hospital length of stay, lower hospital costs, a decreased risk of bile duct injury, and ultimately low rates of mortality. However, some patients have complicated cholecystitis or a high perioperative risk, and for these patients that have the presence of gallbladder necrosis, perforation, abscess, or fistula, often these patients have to undergo open cholecystectomy or subtotal cholecystectomy. Ultimately, for the non-surgical candidate, we have three main options for people to decompress their obstructed gallbladder. Traditionally, this has been done with percutaneous cholecystostomy, and that can be done through a transhepatic route or a transperitoneal route. This is minimally invasive and widely available in most hospitals and institutions, with a high rate of technical and clinical success. However, what we've seen that this is not definitive treatment, and often leaves people with a percutaneous drain that requires exchanges and upsizing, and without a clear goal or clear endpoint in mind, with frequent reinterventions and a high rate of adverse events and clinical morbidity for patients. Another option for people is endoscopic transpapillary gallbladder drainage, in which case via ERCP, we're able to selectively cannulate the cystic duct and place a stent directly into the gallbladder to perform transpapillary drainage. This has a high rate of variable technical and clinical success. As you can imagine, the cystic duct is often obstructed, and we may not be able to place a stent into the gallbladder. So it's not definitive treatment, and there's the risk of pancreatitis for patients with ERCP. The newest member to the group here is the EUS-Guided gallbladder drainage, and this has demonstrated high rates of technical and clinical success with a relatively low adverse event rate. The nice thing about this intervention is that it can provide permanent treatment option for some patients. However, you must also consider the how it may affect future surgery for some patients. And as you can see here in the CT scan of the lamb stent sitting in the gallbladder in the bottom picture. So there's been several studies, and pooled data from both retrospective and prospective studies have shown the performance outcomes for EUS gallbladder drainage. It demonstrates high rates of technical success, high rates of clinical success, with low rates of recurrent cholecystitis and procedural related adverse events, and generally well accepted overall adverse event rate of 17 to 25%. EUS gallbladder drainage also shows that the outcomes tend to show lower rates of recurrence, reintervention, post-procedural pain, and shorter hospital stays, and fewer adverse events when compared to percutaneous gallbladder drainage. And so this has kind of been the new player here that people have been most excited about and have demonstrated good success with. As we know, patients with cirrhosis tend to have higher rates of cholecystitis, and this is due to a high rate of gallstone-related disease and cirrhosis due to complex physiological changes related to their liver disease. And we also know that patients that undergo cholecystectomy have high rates of postoperative complications, and that's generally for those who are child class C or MELD score greater than 13 with decompensated liver disease, as they pose a greater technical challenge surgically, have higher rates of bleeding, and ultimately high rates of hepatic decompensation, and potential requiring liver transplantation. This, coupled with other comorbidities associated with age and medical disease and the presence of clinically significant portal hypertension, makes cholecystectomy a challenging endeavor for patients with cirrhosis. This chart shows that there's an increased proportion of patients with liver disease undergoing cholecystectomy, which tells me that the population of patients developing cirrhosis and gallstone disease, as with most things, is increasing over time. This recent cohort study showed that patients who undergo elective cholecystectomy with cirrhosis have a 3-time higher 90-day mortality rate than those who do not have cirrhosis. So, ultimately confirms what we know, that patients with cirrhosis undergoing cholecystectomy is a tricky process. This study sought to evaluate the safety and effectiveness of endoscopic ultrasound-guided gallbladder drainage for patients with cirrhosis. And to date, this was published this year, and to date is the largest study evaluating this intervention for people with cirrhosis. It's a retrospective study and who evaluated the outcomes of these patients, 170 patients in total, 47 of who have cirrhosis. What they found in the initial data gathering, that there was no clinical difference or no statistical difference in patients' characteristics, and patients with cirrhosis had a mean MELD sodium score of 16.2. What they found post hoc was that the technical success rate matched what is known in current literature of 97.9%, with a clinical success rate of 93%. And then furthermore, what they saw is that the EUS gallbladder drainage was performed more frequently for acute cholecystitis in patients with cirrhosis, and that adverse events were infrequent but similar between the groups, with similar rates, low rates of early bleeding, late bleeding, and stent maldeployment. And ultimately, what the authors concluded, that EUS-guided gallbladder drainage was safe and effective in patients with cirrhosis, with outcomes similar to patients without cirrhosis, and that this tool may fill the therapeutic gap for patients with cirrhosis who also have acute cholecystitis, who are too high risk to undergo cholecystectomy. So what we see is a paradigm shift in our treatment strategy. When traditionally patients were relegated to percutaneous drainage and the adverse events and discomfort associated with a percutaneous drain, we can now offer patients internal drainage, either through transpapillary drainage, but more frequently transmural drainage with EUS-guided gallbladder drainage, as we see in the picture on the right. So comparing these two modalities, this recent study showed the safety and adverse events of EUS-guided gallbladder drainage using lumen-opposing metal stents and percutaneous cholecystostomy tubes. And it was a large meta-analysis with random effects model comparing these two treatment modalities, including 6 studies with 710 patients. And each one of these outcome measures, they saw that EUS gallbladder drainage performed better than percutaneous drainage with regards to delayed adverse events, overall adverse events, reintervention rates, recurrent cholecystitis, and hospital readmissions. And even though it was not clinically significant, the length of hospital stay was shorter for patients who underwent EUS gallbladder drainage, suggesting that overall this treatment provides better outcomes for our patients. And so pooled results from several contemporary studies which suggest that EUS gallbladder drainage has better 30-day adverse events rate, a better 1-year adverse event rate, less amount of reinterventions, as it can be a more permanent solution for people, decreased risk of unplanned readmissions, a decreased risk of recurrent cholecystitis, and most notably, or what I want to point out, is that patients are better satisfied with internal drainage of their gallbladder, as they don't have to deal with the cumbersome external drain, the cellulitis that can happen, the discomfort, the pain, and all of those factors that can be associated with percutaneous gallbladder drainage. And so in 2023, our American Gastroenterological Association incorporated EUS gallbladder drainage into our treatment algorithm for patients with acute cholecystitis, and who are not surgical candidates, in which case we now frequently think about this treatment modality for our patients and as a definitive treatment. This study was recently published to also consider that for some patients who may be a surgical candidate, that maybe transmural drainage is not the best option as it can complicate their surgical resection in the future. This study evaluated patients at their institution who underwent U.S. gallbladder drainage, and 3 of their patients had their surgical candidacy reversed and were able to undergo cholecystectomy. However, each of those patients had to be converted to an open procedure because of the fistulous tract that was made with the Lamb stent and surgical repair that was needed. So the authors concluded that U.S. gallbladder drainage should be reserved for a selective cohort of never surgical patients, and be selectively provided. So the right patient for U.S. gallbladder drainage would be the non-surgical or the never surgical patient. And, this is primarily driven by the surgical service who makes that decision based on a Charlson Comorbidity Index and maybe ASA scores. The patient that has uncomplicated cholecystitis, specifically patients without gallbladder perforation, could be candidates for U.S. gallbladder drainage. And ultimately, this is based on consensus from a multidisciplinary discussion, involving our surgical colleagues and even the interventional radiologist about who would benefit from U.S. gallbladder drainage. It's to ensure that everybody is in agreement on that decision. So in conclusion, EUS gallbladder drainage offers a safe, effective alternative to cholecystectomy with a favorable risk profile for the non-surgical candidate. Major societies around the world have incorporated and concluded that this is a viable treatment option and have placed this into their treatment guidelines. Going forward in the future, we will continue to consider expanded indications for U.S. gallbladder drainage based on the patient comorbidities and who is at high risk for surgical resection. However, more data are needed to incorporate widespread adoption into our treatment algorithms to care for these patients with acute cholecystitis. Thank you.
Thank you, Dr. Orr, for that very interesting presentation. Given the use of GLP-1 agonists have exploded and the 30% incidence rate of cholecystitis in patients that use GLP-1 agonists, is there any role that this would have in managing their cholecystitis, or would you just recommend they go directly to surgery?
Yeah, I think where we're at now, I think surgery still is king. And understandably so, as offers the most definitive treatment course. However, with this therapy, we're often able to clear the gallbladder, remove all the stones, and then we can remove the stent and leave them stent-free, or we can even place a plastic coaxial stent into the gallbladder, which maintains that fistulous tract. So all that to say is, I think endoscopic therapy can be a definitive treatment course. However, for some patients who are young, fit, and healthy and want to be over and done with this disease, having surgical resection is still the best route.
So we have time for one question. Dr. Wolf, if you want to unmute yourself, and this is a question for both Dr. Doblecki-Lewis and Dr. Orr.
I actually asked online, tying the two talks together, which were excellent. I've always thought that gallbladder drainage or any kind of intra-abdominal drainage is analogous to an abscess, which is the most important treatment of any infection. Are there any studies looking at short courses of antibiotics afterwards?
You want to ask that, or you should let Dr.
Yeah, we'll let the expert on antibiotic use.
I agree with you. I think it is analogous to an abscess once it's drained. And assuming that there's no other focus of infection, I think that the short course therapy is appropriate. We know, I think the Stop It trial looked at uncomplicated intra-abdominal infections and after drainage and resolution of any focus of infection that required drainage. I think that those findings would apply to this situation as well.
Thank you.
And that would mean oral, potentially. Oral or injection. Okay. Okay, thank you. Okay, well, I thank everybody for participating in Grand Rounds today. Please check your chat for the CME and MOC codes or on your way out. Everyone have a safe Memorial Day weekend, and we'll look forward to seeing you next week.